Welcome everybody to this first summer webinar. Right, so we're starting a webinar. So it's the first summer webinar for the UKDHC, the UK Digital Health and Care CIC, which we started just over a year ago to try and improve digital health and for everybody working in the health and social care sectors in the UK and even internationally. Our aim is to improve education and to also liaise with colleagues both in the NHS, both the third sector, and to make life and working practices in health and social care much better for everybody concerned, and to also deliver better service to patients at the end of the day. So the topic is reducing cancellations and optimizing theatre usage with a digital perioperative pathway. Right, so I was talking about using pathways in the perioperative setting and basically moving away from the old-fashioned paper-based type of process where we have a outpatient-based assessment of patients, then followed by them coming to a formal perioperative or preoperative assessment clinic, and they seen in person. Usually it was done for an hour fixed slot appointment, and then the patients would be assessed and given the all clear to proceed to surgery, or if they needed any further investigation or further management, that would be identified, and then the patient would be slotted in for the appropriate investigations. Now, the system was actually quite effective in the way it used to work, but obviously left a lot to be desired in terms of patient comfort, patient experience, and it was not very flexible in terms of moving things forward. So in the 21st century, we certainly could do a lot better. So I am going to just talk about the experience in NHS Lanarkshire. As always, bringing in any kind of digital system into the health and social care sector is always fraught with problems, and it's not necessarily the technology that is the main barrier. Quite often the biggest problems or the biggest barriers are related to culture, to engagement, and to change management, and devising new ways of working. In the NHS, we have been historically very slow at adopting digital initiatives, and a lot of it is also due to the fact that there's been a lot of resistance about changing the mindset from the previous working methods to new, more flexible methods. But that certainly is a wake-up call for us all to move to better ways of doing things going forward, because to be honest, the current or the previous setup is simply not sustainable in the long run. We do need to do things better. So just to talk about myself, I'm Dr. Jacob Nicolas Francois Talliard. I'm qualified MBCHB in 1994 from the University of Pretoria. I did my secondary care training in the UK and qualified with a fellow by examination for the fellow Royal College of Anaesthetists in London in 2007. I'm a member of the British Computing Society Chartered Institute for IT, and I hold an MSc in Health Informatics from the University of Sheffield. I'm appointed as a consultant anaesthetist in a substantive post in NHS Lanarkshire and has been there since 2009. Fulfill clinical safety officer duties through my company called Summer UKDHC Limited. I'm the CEO and director of multiple companies, and I'm currently the technical director and one of the founders of the UK Digital Health and Care CIC. I'm also a part-time PhD investigator at the School of Engineering for the University of Strathclyde, part of the Future Hospitals cohort. So just to talk about what we did in NHS Lanarkshire in terms of moving things forward, we realized in 2015 or circa 2015 that we needed to find a way of having a digital perioperative pathway. We established a whole lot of what we wanted the system to do. We wanted a very flexible system. We wanted it to be able to take all the hard work we'd done before in terms of the paper-based systems that we had in place. We wanted to rationalize that and come up with a more streamlined, better system that was digital, that allowed patients to fill in their information remotely, and that allow us to pre-assess things before we see the patients as early in the possible pathway as we can, just to improve things. We also wanted a two-way communication system built into the system so that we can connect the clinic directly with our patients and be able to ask them questions about medications or clarify any issues that they might be in their health, or what medication they're taking, allergies, etc., etc. So in terms of NHS Lanarkshire is the third largest health board in NHS Scotland, serves a rural and urban population of 665,000. And we have 3 acute hospitals, University Hospital Hermite, University Hospital Wishaw, and University Hospital Monklands, and comprises a lot of different surgical and medical specialties, some of which are concentrated on specific sites. So, for example, in University Hospital Monklands, we have the urology service and the ENT service for most of NHS Lanarkshire. In terms of bringing in NHS LLC, we have eliminated a 2-month preoperative waiting time to practically zero. We can slot patients in very rapidly, and we had a 33% reduction in surgery cancellations since bringing in LC. Now, LC was not brought in as one foul tranche as a pre-developed system, just fit for purpose. We designed it based on our current process in NHS Lanarkshire, and then have been incrementally improving and building on it since our initial rollout of the system. We now have about 45% of patients could actually attend and do an assessment without actually attending the hospital itself. So, right, let's move on to the different slides. Those are just images of the different hospitals. So, in terms of what we found, we have an app based on smartphones, which is available on the app stores for both the Google and the iOS. And as I've already mentioned, we've 35 to 50% fewer cancellations based on this. Patients have consistently found the app to be very useful and consistently rated way over 4 out of 5 stars. So we use the app to the pathway from Buddy Healthcare, which is one of our UKDHC corporate sponsors, but also a company built from Finland who built the pathway platform, which is used not just for perioperative medicine, but also used for many other specialties, both medical and surgical, in terms of coordinating patient care. And the system allows for questionnaires to be furnished to the patients through the app. Patients can fill that in. They can get care-related instructions. They can get instructions on prehabilitation and how to get their physical condition improved prior to surgery. We send out reminders of fasting and medication advice, and we can do pre-surgery checklists and reminders as well to ensure the patients remember to do the fasting and can present themselves to the hospital at the right time and date for the surgery. They also get instructions in terms of where to go and the process of coming into the hospital itself. We can also furnish questions post surgery in terms of wound care. We can also potentially use primes and proms on the system and do some reporting and analytics to use to improve our service further. So the traditional preoperative assessment service was pretty much according to the current pathway as I'm displaying now. As you can see, lots of individual points and lots of decision points as well. And part of the development was to try and cut this down and to remove some of the steps to make things faster, easier, and more manageable for both the patients and for the staff working in the preoperative assessment clinic. So currently, patients are normally seen in a surgical outpatient clinic by a surgeon, and there will then be a discussion and a shared decision-making process engaged on whether the patient would, one, be needing surgery in terms of clinical indications, and then whether the patient would wish to have their surgery, and that would then be scheduled. So now we get the patient to be invited to our digital preoperative assessment service, which then sends the patient a text message and allows them to download the app from the relevant app store for whatever smart device, whether it be a smartphone or a tablet device that they're using. The patient will then fill in the preoperative assessment forms in the app and give us all the information that we need to make decisions or to help them and assist them. The patient also accepts a patient declaration in terms of the information that they provide. And we also gather information both not just from the physical status, but also other parameters like smoking, weight, and other social factors that might impact on their actual surgery. So whether they live alone, whether they have supportive partners, whether there's family members who can help them through it. The system also allows for those people who do not have the ability or struggle to engage on digital platforms to have a member of the family or a care or people from their carers team to actually fill in the information for them. So up to 5 people can be invited to the care pathway of the individual patient to help them fill it in. Once the digital records are pulled in, they are reviewed by the nursing staff, and if necessary, they are then passed on to us as consultant anesthetists to determine whether we need further anesthetic review or whether the patient is fit for surgery. The vast majority of patients are actually deemed fit for surgery by the nursing staff, and it's only about a third of patients at most who get referred for anesthetic reviews. After the forms are completed and the patient filled in all the details, the decision is made whether the patient's fit to proceed to surgery. The documents get uploaded into our electronic system, clinical portal, which is based on InterSystems tracker, and all the information, including a day of surgery summary, which is pulled together from the information provided by the patient, is furnished in the clinical portal. So the clinicians on the day of surgery can look up this summary and have a quick and easy way of assessing the patients. So just some numbers and statistics in terms of LC itself. Since April 2022, we have done 12,200 patients invited to the digital preoperative assessment, and 10,550 patients of these started to use the NHSL LC app. Now, LC was actually brought into service in 2020, and the only reason I'm quoting 2022 is because we've started the latest version of LC after that. In the last 12 months, we had 5,200 patients invited, 4,500 patients started using LC app, and 220 patients were assessed by the preoperative assessment nurses, filling in the data in the NHSL LC app on behalf of patients. So these would be patients who might not be able to do that themselves, but could have the nursing staff fill in the details for them, usually done through a video call at the same time. The percentage of patients activating the app has since the beginning been consistently actually over 80% of patients. During July 2024 to November 24, activation rate actually averaged over 95%. So there are some patients who have not completed the system, the preoperative assessment online, the so-called missing PA complete or pre-assessment complete. There are various reasons for this, either change in urgency of the patient's condition, whether the patient needed to be seen earlier or whether they needed some other investigation or some other reason why they needed to be taken off LC and be brought in for face-to-face, or intercurrent illness where the patient would actually have issues and might need admission, etc. And we strive to minimize that at all costs. So patients are invited with in a secure fashion and have an activation code that gets sent to them. And we have two-factor authentication implemented in the service. For NHS Lanarkshire, what would have been the benefits? Flexible schedules. We can plan our autonomy for the nurses and clinicians a bit better because we can review things at more at a leisure, or not necessarily leisure, but at a better pace, rather than having to be constrained to a 1 hour fixed slot at a specific time period. There's opportunities for remote working, and in fact, during the COVID pandemic, we actually had some of our nurses doing remote assessment of patients, which was quite beneficial because these nurses were at the time actually isolating during COVID itself. We now have the ability for multiple nurses who can work in the same room simultaneously. We have improved the consistency of our records as we have the same records, and then we have streamlined our assessments to make sure that we ask the same questions. Previously, we actually had some variance across the 3 acute sites and the 3 acute clinics in terms of what questions were asked, etc., for patients. We've also strived to line up with some of the sort of national developments in terms of a standardized question set for preoperative assessment. We have had some time savings due to needing to scan less paper documents. We have saved some trees by preventing the printing out of documents, and we are ensuring that we make the documents available much more readily for the clinicians and also for patients themselves. We have no longer the need of a paper copy that's put through the hospital. We can have a digital copy that's accessible to anybody who have the rights to access the patient's records through the clinical portal process. And we can expedite our anesthetic reviews to try and review the more complicated patients faster and hopefully provide a better service for them. We also are trying to gain valuable insights in patient preparation process, and we're trying to work our way up to doing full preoperative rehabilitation service to improve patients' condition prior to them coming to surgery. And we aim to be more sustainable by reducing paper usage, postage fees, and also to reduce the footprint, the CO2 footprint, by patients not having to come into the hospital necessarily. One of the biggest boons as well is especially for that younger group of patients who are economically active, who do not have to take time off work to necessarily come and see us in the clinic. Previously, we had at least 10 pages of paper, and so of ready reckoning in the last 12 months, NHS Lanarkshire saved about 51,600 pages of paper and £3,500 in paper and printing costs, not even counting additional costs to administrative process that have not been taken into account, such as scanning, filing, storing, retrieving documents, etc. Since taking NHS LLC into use, we have been able to complete more pre-assessment at the same time due to less time spent per patient. Patients complete the pre-assessment digitally, and the pre-op nurses can then review it. The remote work, as I've already mentioned, there's an opportunity for nurses to do remote working and for consultant and anaesthetists to actually do remote anesthetic reviews. and we can utilize the room spaces better. We have, again, as previously mentioned, improved the convenience for patients, less travel to the hospital, it's less time consuming. Patients can fill in the questionnaires from the comfort of their own home and sofa. All information is in one place and all patients receive a similar set of questions. So in terms of how long does it take patients to complete it, the vast majority of patients can actually complete the question set in less than 1 hour. As you can see, less than a very small minority of patients take more than 24 hours to fill in the question set. These patients are usually patients where there's special needs or patients who are highly complex, and sometimes they need to wait for special investigations and other results before they can complete their information. Now, in terms of has the LC been effective? Has it actually made a difference? So I have looked at the data, and I've looked at the Scottish Government's Public Health Service publications and updated the data as of yesterday to the data available to the end of February 2025. Now, looking at the impact of NHS LC on surgical cancellations, there are various ways the data is recorded. The data is recorded as clinical reasons, patient-initiated cancellations, non-clinical capacity cancellations, and then a total cancellation rate. Okay, so in NHS Lanarkshire, across most of NHS Scotland, the total cancellation rate has remained relatively stable at about 10%, or just around about 10% for most health boards. The clinical cancellation reasons have reduced significantly after we introduced NHS LC from 3.56% to around 2.5%, which was highly statistically significant to a p-value of p less than 0.001. The patient-initiated cancellations increased slightly. It's not 100% clear why that is, whether it's due to patients being better informed or whether there's other reasons why patients might have decided to cancel their surgery. However, there has been no real change in any of the non-clinical capacity cancellations across NHS Lanarkshire, and that actually has remained the same for all the health boards across NHS Scotland. We've done some predictive modelling to see what the effect of increasing LC over the short term and longer term would be, and what would be the impact if it was to be rolled out across NHS Scotland in One for Scotland type of model. So currently we're using around about 30% of the capacity for LC, and hopefully we are making progress and getting this up closer to 100% in the near future. We will never actually reach 100% because there will always be a small group of people who will not be able to use the digital systems, and therefore will need some additional help. If we wait no difference, if we carried on at 30%, the predictive modelling suggests that the cancellation rate will continue to hover around 10%, at least for the next year, and probably for the longer term. If we simulate the 100% adoption of LC in NHS Lanarkshire, we can predict that the reduction in total cancellations could be as much from 10% down to 7.6%, and a 25% overall reduction in surgical cancellations should be easily achievable. This evidence suggests that NHS LC is highly effective in reducing clinical cancellations, and that full adoption of NHS LC across Lanarkshire and potentially wider could provide significant additional benefits. So the questions then to be asked, what if NHS LC was rolled out across all of Scotland's territorial health boards? Now, initially the implementation of NHS LC was funded by the use of one whole-time equivalent Band 5 Agenda for Change staff post, which is circa £32,000 per year. That was our initial investment cost. And I looked at what is the return of investment, the realization speed of the return of investment, and what annual savings can be generated. So the annual financial benefit from the modeled reduction in clinical cancellations works out to about £288,000 per year, and that equates to a monthly saving rate of about £24,000 per month. And the payback time for the one full-time equivalent band 5 staff post is about 1.33 months. And initial data suggested that it could have been about as short as 8 days for the initial investment to be recouped in terms of savings. If it was to be rolled out and it was successful across NHS Lanarkshire, there's a potential to save upwards of £7 million per annum in terms of generated savings. And that's basically all the statistics that I currently want to put forward. I would now open the floor to anybody who wants to ask any questions or make any comments, and we're particularly keen to hear from Dr. McConnell to see if she wants to put some comments as to the implementation of ALSI and where we're going and what the benefits we want to see.
Francois,
Shona, over to you.
Thank you very much indeed. And we will ask Shona to come in a minute. Can you hear me clearly?
Yes.
I think, Shona, what we want to know, for those who know nothing about ELSI, is ELSI text-based or is it audio-based? Is it an app that speaks to you, or does it just send you messages?
So it's an app where you read the information, you read the questions, and you can reply to them.
So it's text-based.
It's all kind of text-based. There are obviously you can change the kind of size of it, and you can use text to actually talk to the pre-assessment nurses as well while you're using it. So there is a human at the end of it, and you can actually use the messaging function at the end of the app in order to ask the pre-assessment nurses help if they have difficulty with any of the questions as well.
Yeah.
And also there's the availability of them to actually phone the pre-assessment departments as well. So all the telephone numbers for the 3 different pre-assessment departments we have in Lanarkshire are available for support as well. But I would say a lot of patients, if you're going to be using the app, people are very much using the messaging system. So it does actually reduce the amount of phone calls a pre-assessment department gets during the day, which when you have to stop what you're doing and answering phone calls can be quite kind of intrusive to the nurse's work. So if they can just sit and then look at all the messages that they get from a day, then obviously it can streamline their work from replying to the patients on the app as well.
That's very helpful. And it's interesting to see how life has changed, because in the past, when mobile phones were popular, initially, people always phoned. Now it is much more common for people to text and not use real time for communicating. Unfortunately, our elderly patients haven't quite got to that stage. Did you find a difference between the elderly using ELSI and the middle-aged and younger patients using ELSI?
So actually, sometimes the younger patients or the middle-aged patients are some of the people that don't engage particularly well and need reminded to actually get down and do the paperwork and do it. I think older people, if they're going to do it, are better at getting on with it. I don't know if that reflects free time or the fact that they're just going to do it, and the younger population have I'll get to that at some point. I think if you agree to do it and you're going to do it, I think a lot of people then will manage to do it fine. And actually, whether that's an age thing or not, yet potentially the older population who don't want to do it will not want to do it from the get-go, in which case there's always the accessibility to just have a traditional telephone appointment or inpatient appointment or video appointment. For the older people who have accepted it and have gone on to do it, we've had patients in their 90s that are capable of having a smartphone, using the app and answering the questions appropriately. So it's not there's no age limit. There are a lot of obviously silver surfers out there who are quite happy using it. You will always get people who don't. I think as we go another 10, 20 years, I think the proportion of the older population who are unfamiliar with smartphones or apps will gradually be decreasing, and it will become something that's less of an issue, I suspect.
Right, can I please ask now for any questions from our audience? Please put your hand up. Fleur, can you put your audio on and ask your question?
Yes. Okay, so I'm the manager of neuro outpatients down in UH Sussex, which includes pre-assessment. All of our patients that have pre-assessment need blood swabs and observations. How do you get around that if you're just using an app? There's nothing face-to-face, whereas GPs down here definitely won't do anything.
So we have separate band 3 CSW clinics. So so it actually means that they come in and do that instead. So it means that you're using a band 3 CSW for investigations and things, and that you're using the band 5 nurses for actually what they're more qualified to do, and actually using them for their skill set of assessing and triaging the patient.
So they still need to come in.
Yes, and sometimes that is what the expectation when some people say, "Oh, well, there's a digital assessment. You can have someone assessed in 24 hours." That's all. Well, yes, you can. If they're a young, fit, healthy ASA1 going for minor or intermediate surgery, you might not need any investigations. Alternatively, you might have someone who has investigations that are already on file on portals. So when the nurses are reviewing the patient, there are some people obviously who need investigations, some people whose relevant investigations may already still be in date, and we have protocols about what they can accept as recent and appropriate ECGs and bloods, etc. And for those that aren't, we schedule them into the band 3 CSW investigation clinics.
So do they do the app first and then they get booked into the clinic? Okay.
Yeah.
Right.
Yes.
Sorry,
So Fleur, to give you a little bit of alternative background, in the area that I live in, the hospitals can order bloods to be done at centres, usually GP surgeries, before you go and attend your clinic appointment. The only problem with that system as it works at the moment in Nottingham is that the consultant has to write out the hematology and blood forms and post them to you in order for you to get them, in order for you to go to the surgery to have your blood taken. Now, that is a little bit not joined up. But if any of you want to know a little bit about not joined up, I have posted something on digital health networks, which you should go and look at, because it highlights how a lot of communication at the moment within the NHS is not linked up, and that creates additional problems. So Scotland appears to be slightly ahead from the joined up point of view, but it doesn't have the NHS app functioning at the moment, I don't think, Francois, does it?
No, it doesn't. The NHS app is purely England and Wales. It's not been taken up on NHS Scotland. There is moving to a similar system in NHS Scotland, and in fact, NHS Lanarkshire is down to trial the digital front door, as it's to be called, for NHS Scotland by the end of 2025. So there's a project board who's working on that, and we're making sure that patients can see their appointments, etc., in an app to try and improve things further. So just to address some of the things you said there, Angus, we are lucky in NHS Lanarkshire that we've brought in ordercoms, which is our electronic ordering system for things. So the clinicians actually have the benefit of being able to order the investigations on the electronic system, so the patient doesn't have to get paper request forms and things sent out to them. They literally just get a dated time to come and pitch up at whatever relevant investigation clinic, and all the bloods and things will be done because it's all electronically requested and ready for them to do.
Very good. We'll come to Emma now, who's got her hand up, then DJ, and then Andrea from Romania. I'm going to get Andrea involved to find out what Romania does. Emma.
Hi, thank you very much. That's very informative. I've got two questions. One of them, do you use a system such as GraphNet that has a triage service within that app that shares records from GPs?
Currently in NHS Lanarkshire, we certainly have our GP records. We have GP summaries that comes from the GP records, but that's integrated mostly into clinical portals. So that's the main hospital system, not integrated into NHS LC in particular. Okay. We aim to have closer integration with all the digital systems. We're working our way towards that. Right. Hopefully we'll get some better integration up soon. As always, there's all the hiccups of governance and all the rest of it to get past to make sure everything joins up. So in some ways, yes, it's good because we can actually look it up as clinicians on the system, but there should be better ways of doing it, and we are working on that currently.
Okay. So I would say that our nurses who are reviewing the questionnaires from Elsie are cross-referencing the GP summaries.
Right, okay.
What they're answering, so that they know that the two measure up. So if there's things appearing on the GC that they're not mentioning at all, they can question the patient about it, because maybe the patient has forgotten about things in the past, or things that don't actually appear in the GP summary. There is a bit of truth, and sometimes that's a bit of a cross from the two bits that are appearing. Okay. We have the medicines reconciliation, where you have what the kind of emergency care summary, what the medications that the patient is on, and what they say they're taking. So there is some of that goes on as well to ensure that what the day of surgery summary form is actually what the patient is taking.
Okay.
And I just jump in there and say as well that soon as they raised the medicines reconciliation, that has always been a big issue. And what we do know is that patients aren't taking what is recorded on the system, whether it be in the GP system or elsewhere. So we have the multiple sources of information. We have the GP records, the GP summary, and we also use what's called the emergency care summary in Scotland. And we can cross-correlate, and then we look at what the patient actually supplies as information in NHS LC. And part of the reason is we could have pulled just the information out of the GP summary or just out of ECS into LC, but we've specifically left it open for patients to actually fill in what they put down as to what they use, because at the end of the day, the final arbiter is what is actually being used by the patient, and regardless of what's written down anywhere. One of the advantages of the messaging system is that patients can actually take images or even videos and send it straight to the clinic, so that if they have a bottle of pills or something and they don't know what it is, or they're not 100% sure, whatever, they can actually send an image to the nurses who can look and check that what we think the patient is on is actually what the patient is taking.
Okay.
So, DJ, you've got a question. Then Fleur.
I had a second question, but I can come back.
Okay.
It's fine.
No, it's okay, Emma.
Sorry.
Give me your second question.
So I'm the matron for pre-op assessment at Buckinghamshire Healthcare, and how the patients that need prehabilitation, so they're not deemed fit, they need interventions, smoking cessation, weight loss programs. How are they tracked, and where does that information come from? Is that done by your pre-op nurses that then follow those patients up, or are they signposted to a prehabilitation team? Or
it's more signposting to smoking cessation, or for alcohol, or for kind of the weight loss. If it's those cases, they're quite often then, if it's going to be a significant length of time, they're quite often paused from the pre-assessment and sent off. We come back in when they're more suitable for surgery.
And can you, on your system, can you pause them so they still kind of stay in the system so you have visibility of them? Yeah, okay.
Yes.
Yeah, good. And things like blood pressures, uncontrolled diabetes, is that is that back to the GP to monitor and optimize? Yeah. Okay.
Generally.
Okay, thank you. It feels like we're doing all of this at the moment, so that's really interesting to hear. So
DJ, over to you.
Thanks, Angus. DJ Hamlin Brown, fellow director of UKDHC, for those that haven't met me before, and budding digital health entrepreneur. So I'm obviously very fascinated to see the work that you've done. This is a commercial question, which maybe neither of you can answer, but I'm interested to know why Lanarkshire went for a grow your own version of this when there are several, I would say plenty, of commercially available versions of such pre-assessment software available on the market, which you could have taken off the shelf. Have you any thoughts about why you decided to actually develop your own?
Yes, so I would say it's been a relatively long-term time in coming. Say the whole process started with some meetings in 2015. And if you go back to 2015, there wasn't actually very much in terms of these kind of systems available at the time. And certainly they did not meet the criteria of what we wanted to see or use. Most of the systems at that time did not have any form of two-way communication or asynchronous communication, and lacked the ability to necessarily have bespoke question sets at the time. So that we wanted to use all the knowledge and experience we'd gained in our pre-operative assessment up to date, and to try and use what we've already learned and make it better and implement it. So that's part of the reason why we did that.
Can I ask, how long did it actually take to go from, if you like, first specification to actual launch? I mean, was that many years? 2015 is literally a decade ago. You tried to do this, or sort of doing it, and now here we are celebrating it. But we're not celebrating 10 years of use, are we?
No. So essentially, we only really got the funding and the monies for this as part of the COVID, where we were doing our nurse clinic, 1 hour, see the patient, do all the bloods, etc. And then obviously pre-assessment completely halted in kind of March, April 2020. And then we realized at that time that we had actually a digital assessment where you didn't have to bring patients into hospital. We needed to start thinking about. So that is the time where we kind of got the business plan, and finally, having been nagging at them for the 5 years, which was mostly Francois and less me, we finally kind of started it up then. I would say it took us about a year to actually get all the questions, get all how we wanted all the branding, get everything up and running to what we thought was the best way of doing it. I would say we ran that first version of it for a couple of years, then rapidly realized actually how we wanted to use the system and the question set that we wanted to use, and how we wanted to look at how best we used it for the nursing side of things, because the patients are also, you need to see how they interact with whatever system and how they answer the questions, and you can find better ways of answering questions. So we did a bit of a rewrite and a nuanced and called it LC2, or the kind of the pathway that we launched about, how long ago was that now, Francois? A good year and a half, 2 years?
Just about a year and a half.
Yeah.
Just about.
And also with that way that we redeveloped it, we actually thought actually for the nurses, in order for the nurses to use the digital dashboard, but still be using the telephone and the in-person or the telephone assessments, where the nurse is actually then using the digital data set to still generate the same day of surgery summary form, in order that we can actually start nurses doing home working. That's another reason why we kind of rejigged it kind of a year and a half ago.
Interesting. So you're on version 2. Sorry, I'll stop in a second, but I just want to say thank you very much for that insight. And I think what the guess before we start, we can come back to this question is, how might Lanarkshire spread the good news and start using this for other, and you mentioned other Scottish boards, but you know, every hospital should be doing this if they aren't already. So it'd be an interesting question maybe to come back to about how you might commercialize it.
Yep.
I think we'll leave that. We'll leave that, DJ, because that's just a little bit political at the moment. Fleur,
yeah, that's why I said we should come back.
Is that a historic
Can
hand,
I-
or have you got another question?
Hi. I just also wondering how long are the pre-ops valid for, and how can you then go back on? I mean, do you go back in it and they have to repeat it? I mean, we have unfortunately a lot of cancellations, not to do with the pre-op, but just for other reasons, beds and things like that. They would then have to have another pre-op at some point. How do you manage that?
So we have update paperwork that we can add in. So the original assessment stays, and then we have an update form with any questions. Has anything changed in your health? Have any medications changed? And those sorts of things. Validity of pre-assessment and validity of test results for preoperative is a bit of a kind of hot topic, and it's something actually we as a group in Scotland have got together and are just discussing, because sometimes validity in different areas or different regions is a bit different. How do you decide who warrants being a 6-month validity? Some young, fit, healthy people waiting for kind of elective knee surgery might be a year validity. So that is something itself that there's no clear answer for, and there's no clear answer for validity of test results. We have currently just extended up to 6 months, and we're trying this as a trial, so that now our pre-assessments last for 6 months. And actually we're trying to do a push towards schedulers to ensure that they are listing these people in the 6 months time, because clearly repeat assessments and reviews take up valuable pre-assessment time, and it reduces your pre-assessment efficiency if you're having to reassess patients all the time, which can happen as much as up to 10% of our assessments are repeat assessments because people, for whatever reason, have not been listed. So we do have the paperwork attached to LC, so we can do that. We've extended it up to 6 months, and we obviously have protocols for our nursing staff about when we can take bloods from, because obviously the bloods might, as I said, might predate the assessment, in which case we're not going to bring them back in for repeated bloods if they've already got a set that are sitting there from 2 months ago. And we have obviously things like ECGs. So for the review appointment, the assessment is valid for 6 months, and then the review appointment might precipitate just a health check and a brief review, which is done on LC, or it might require an extra investigation appointment as well. But that is something
I just jump in there.
to our working.
That's lovely.
I'll just jump in there
Thanks.
and make a comment as well, Angus, just to say that the evidence, as always, from the Royal College of Anaesthetists and from other sources, are that we tend to over-investigate patients for perioperative reasons, especially the younger cohort of patients who don't have a lot of medical problems. We tend to do tests on them that are really not warranted or needed for them to have simple procedures. So we try and cut back on the testing where we can in a logical fashion, and only do those tests that we really need to do. And then, of course, it depends on the actual patient group. So, you know, if you have a patient coming for renal vascular surgery, creation of vascular access procedures and things, it's a completely different ballgame from somebody coming from a routine arthroscopy.
Right, we'll come into Andrea now, and then Rich is going to come and ask a question. But Andrea, I'm always aware that other countries do things more cleverly. I remember when I was out in Malaysia in 1998, I came across the first paperless hospital that was being created in Kuala Lumpur. That was 25 years ago. So other countries sometimes do things better than us. What about Romania, your experience there?
Well, because I work in public health, I don't have experience with the private sector. The private sector, I think, uses already some of these things, particularly with the PROMs and the PREMs. They're interested in outcomes as well. I'm not sure about the pre-operative timing, which is very important, and I'm really impressed with the Scottish app. I mean, it's fantastic to save all that time, and obviously I would like to get my head around the cancellations. I mean, why are they around the same sort of proportion, 1 in 10 in total? However, reasons being different from paperwork to digital, you know, there might be different reasons. But that's, I guess, something for you to find out fast. I mean,
so can I jump in there and say, I'm just going to make some comments. So I primarily trained I grew up in South Africa, and I trained there, and I worked in the military in South Africa. And way back in 1994, plus I was a military medical officer in the military medical service in South Africa. And we had a wide area-based network of several acute hospitals that also included all the what sort of general practice setups. It's called medical sick bays. And all these were fed into a Unix-based system that you could access anywhere in the country as a military medical officer. So I was actually quite horrified when I came to the UK to find piles of paper notes still lying about the place. Now, saying that in 1994 or whatever, we didn't have the facility to have the fax x-rays and the actual images available, but we had all the reports and things available. So that was quite interesting and useful for us to use. And you could actually see a patient who is normally based 1,600 kilometers away in Pretoria, who had a fall during their holiday in Cape Town, and you could access their records and use it. And this was, as Angus says, way more than 25 years ago. And so, you know, we definitely do need to move things forward.
Rich, can I introduce Rich, who is worked with Buddy Healthcare? And Rich, you've got a question.
Yeah, it's Angus, it's really interesting. Obviously, the numbers that Francois produced on the theatre cancellations. However, has there been any tangible clinical benefits to Shona and Francois in the way that they clinically operate? So has it changed in the way that they may do things? Because sometimes we look at it from a finance side, or sometimes just from the patient side, but clinically, has it changed the way that you may look at things, or timing saved, or things like that? I just wondered, because sometimes those things are not always represented.
So I would say one of the biggest benefits to the nursing staff has been then a significant amount of portion of patients are now being pre-assessed, but it's not fixed to a specific date and time. If you think about doing pre-assessment clinics, if you've got one nurse who's got the 7 or 8 patients that they either have to see in person or on telephone at those specific times, if the patient doesn't show up for that appointment or kind of doesn't answer the telephone, and a lot of patients don't think a telephone appointment is like a proper clinical coming into hospital appointment, quite a lot of them are in places like supermarkets or don't treat it appropriately. So there's quite a lot of that wastes time. Also, our pre-assessment nursing staff include a lot of nurses who've come to the outpatient service from other places because of kind of ill health concerns, and our loss of nursing time due to ill health has been quite high. So what previously used to happen is if a nurse phoned in sick for that day, that entire clinic would come down or be lost. What happens now is we've got a certain amount of nurses who are actually kind of floating or covering the digital assessment, so they can actually fill in, and we're cancelling less of the inpatient or telephone assessments that need to be done. So there's less of that rearranging. Also means that the phone, as I mentioned before, they used to get phoned or people phoning back for questions about things. If they're on the app, they can do it as a messaging. So it means that a nurse can sit down and answer questions rather than having to answer a phone the whole time. Also, if you're answering a question on an app and on a dashboard, you can immediately see the question. You can immediately pull up that patient's paperwork in order to have the information to answer the question that they're asking you, rather than, if you're on a phone, having to go and find the paperwork and come back again. So it has changed dramatically how the nursing staff.
What about yourself, Shona? Has it changed the way that you operate?
So yes and no. Yes, in that I use from my pre-assessment sessions, and then there's my anaesthetist on the day sessions.
Yeah.
Okay. So the difference is that when I come and do my preoperative assessment session, I could pick up a bit to review that could be the old-fashioned paperwork, because we've still got that for our in-person assessments. Or I could be picking up the telephone one, which we are currently trying to, in my site, transition over to the LC dashboard. At Francois' site, we've actually been doing a lot of the telephone assessment has transitioned onto the LC dashboard anyway. So it changes how I'm working and reviewing the patient. So I'm still having the anaesthetic reviews and reviewing each by time. Sometimes it's paperwork, sometimes I'm jumping onto the dashboard in front of me. And it doesn't change it dramatically. It just means that I'm using a dashboard, an interface on the computer, rather than writing things on paper. But bearing in mind, for any anaesthetic review on paper, I'd be looking at the patient's clinical portal anyway. So it's kind of a hybrid. So that's not changed it dramatically.
Okay.
For an anaesthetist on the day, it doesn't change it hugely either, because how we've set it up is the output from the LC information as a day of surgery summary goes into exactly the same place on clinical portal that paperwork scanned into goes into. So on the day, I would look up my patient for a list, click onto it, under pre-assessment, click on the pre-assessment, and then it's either the paperwork that has been written in, or alternatively, it's the day of surgery summary form, which we are trying to improve all the time. So actually, what comes into your visual straight away is all the impertinent information that you want to know about a patient. And a lot of development has gone in that over the last year to actually get that as almost an A4 sheet that would help you fill in your anaesthetic form on the day. So yes, in that sometimes instead of having to scroll through a 10-page document, I'm then seeing the digital output, which is a kind of a summary that's been pulled from the LC app information. So it's easier for me to read in the day.
Brilliant. Thank you very
Can I
much.
just jump in there and make a comment? Sorry,
Can
I'm
I
just going to
ask
make a
a
comment.
specific question in relation to the nurse clerking? Because one of the things that I found frustrating was when patients came into hospital, the nurse spent 20 minutes with the patient repeating the questions that were done in the pre-assessment admission sheet. Does that still go on? Do they duplicate that work, or have they produced a very minimalistic assessment that they do on admission of the patient?
So Angus, can I just jump in there and say, so 2 points there. One, in terms of what Sean had said about the preoperative assessment consultant doing the reviews, we're hoping and aiming to try and get better integration of systems and opening patients in context to minimize the amount of jumping between different clinical systems to look up information. So that's a work in progress. In terms of the recent availability of LC2 and the day of surgery summary, I do think there's been a move, and certainly the feedback on the ground from individual anesthetists who are not involved with LC and are not involved in things, is that they find the day of surgery summary to be much more useful and helpful than it used to be to just look at a piece of information that was provided.
Yeah.
In terms of your repetition of information, I think what we've found is that the tone and the interaction has changed in the sense that it's become more of a conversation rather than just rehashing of information. And you find that patients are actually, because of the availability of asynchronous communication or whatever, you can literally just refer to the comment that the patient had made before and carry on with the conversation rather than going and rehashing all the information again. I think that would be fair to say, Shona, wouldn't you think?
Yeah.
So the nurses are changing.
Yeah. One thing that has changed a little bit is I have used the LC messaging system to directly ask questions instead of having to phone a patient up and sit and wait for them to answer. I've also used the messaging system in LC to contact patients directly and ask them about things. And I've also used it to send them things about, I really advocate you having a spinal. Here's the spinal information sheet, and sending it to their messaging system. So it gives you all that additional benefits as well. The only other thing I was going to mention as well is having a standard question set where you ask a set of pre-assessment questions means that you can use the kind of data analyst part of it to find out which questions are really useful and which questions are hopeless. Because the previously you wouldn't be able to look at that information and see it. Now, one thing that's changed recently from RCOG guidance is how you ask patients about alcohol intake. Because previously we had how many units of alcohol do you drink a week? And even on our first rendition of LC, we said, do you drink more than 14 units of alcohol a week, to try and pick out those patients that were at high risk of alcohol.
They'll
Now,
never admit to it.
No, they don't. But new guidance is now you should just be using scoring systems. So like the kind of the, like the fast scoring system, or the asking them how often they drink more than 6 units a week, etc., and score them that way. Now, I've done a recent audit that I managed to pull the information off of Elsie in about 30 minutes, which showed you that if you ask a patient, do you drink 14 units of alcohol a week? You'll get about 5% of people that tell you they do, which is nonsense for Lanarkshire. We know that. If you ask them fast scoring and then you see people who are at risk of alcohol from the risk scoring, as is advocated now since the beginning of this year, you get 10% of patients who are at risk of alcohol. So we're picking up significantly more people than we should be. And we managed to do that change very quickly because we adapt. We have, can go back to people to Buddy Care and say, can you change that question? Because it's we need to ask it in a different way. And actually we've got the information to say, actually now we're asking that question in a better way. And if you get questions like, do you bruise easily, and discover that everybody in Lanarkshire says yes, it's kind of a pointless question. So we just took it out quite simply. So there's
And I just also mention
having a digital question set.
Yep. One of the things we realized in the development process throughout was how very medically centered our questions and our information set was, that it was interpretable by us who speak a different language effectively from the general population, and that the questions and things we were leveling at them did not make sense to them and was rather opaque. So we were getting almost rubbish answers because we were asking questions in a way the patients didn't understand necessarily. So one of the exercises was to actually use the guidance in terms of reading age and rejigging all our questions and redesigning things to make sure that patients were actually speaking the same language and the patients understand what the questions are being asked of them, and they give us information that is useful rather than information that we ended up effectively needing to discard because they didn't actually give the information we need to do the decision making.
Francois, we're going to wind up now. I think we've had lovely presentations from you with contributions from Shona. It's been hugely interesting to find out how this has been progressing in Lanarkshire, and I congratulate you on the progress, because you just didn't take one system and continue to use that, but you actually managed to modify it, upgrade it, improve it, And in doing so, you've got a much more functional system than you started off with. So congratulations for doing that. Thank you very much to everyone who has joined us. And this has been a very informative session. So thank you very much for telling us about how we can do the preoperative assessments more efficiently, more effectively, and great presentation. Thank you all.